Hello, good morning everyone. Today's topic is mumps, diphtheria, pertussis, and myself is Dr. Ram Gopal, Assistant Professor in Department of Pediatrics. You may be knowing all these diseases from second year only, like mumps, diphtheria, pertussis. You will be reading in the microbiology and in the SPM. You think that all these diseases are already we know, and you feel like why there is a repetition again, we have to listen the class. But anyhow, there are some things which you need to know, because these diseases are common in children and these are the vaccine preventable diseases. That's the important, that's why we should learn in pediatrics. And each disease has its own specificity and characters. See, the mumps is the viral disease and diphtheria and pertussis are the bacterial diseases. And before going, and you may be knowing the etiological agent, host, environment, all these things uh, in the SPM and everything. But let me go through the each diseases separately. So mumps. Actually, the mumps meaning is nothing but to mutter like a beggar. Previously, is because of parotid swelling, the child or the person is unable to talk properly, and it looks like muttering like a beggar. So that is the meaning of mumps actually. So that's why the name mumps. And it is RNA virus, belongs to family Paramyxovirus. Mumps is nothing but the acute viral infection leading to the painful enlargement of the salivary glands, mainly parotid glands. So mumps virus has the predilection for infecting the salivary glands and nervous tissues also. Epidemiology. So most common is the childhood disease. Children of 5 to 9 years of age, 85% of infections occur in less than 15 years. Okay, it spreads by human direct contact and droplet fomites contaminated with saliva. So before going to the mumps, we should know the history is like in the Chinese literature. It was mentioned in 640 BC, and Hippocrates in 410 BC he described the complete disease in his book Corpus Hippocratum. In the modern era, it was described by Robert Hamilton in 1970, and mumps virus was discovered by Claude Johnson and William Goodpasture in 1934. So that is the thing you have to know, and it's not necessarily you should know each and everything, but it's nothing but the viral disease. So in the later part of the 19th century, that is in the 20th century, that they discovered it is because of virus. So the virus is isolated from saliva 6 days before up to 9 days after the appearance of salivary gland swelling. In the urine from first day to 14th day after the onset of salivary glands. So how the transmission can be? Virus is isolated from saliva and urine. The transmission is by mostly by the respiratory route and the saliva. So when it is transmissible, so 24 hours before and 3 days after the appearance of salivary gland swelling. So before the onset of salivary gland swelling is also the virus is transmissible. So through respiratory route or fomites or contamination. So what is the pathogenesis? So the mumps virus, it enters the respiratory tract, and it from the respiratory tract it enters into the blood-borne to tissues, and from the blood-borne hematogenous spread, it mainly predilection for salivary glands, so which is the most susceptible. So that to parotid gland is the most susceptible one. So it causes the initially it enters the respiratory tract and viremia to salivary gland. Okay, so the clinical manifestations is like so the incubation period is from 14 to 24 days, and the prodromal features are like fever, muscle pain, especially neck pain, headache, and malaise will be there. So after coming to salivary glands, the pain and swelling in one or both parotid glands can occur. So it's a unilateral or bilateral. So most of the times it will be like unilateral, and sometimes it will be bilateral. So it first fills the space between the posterior border of the mandible and the mastet, and then extends downward and forward. So edema of the skin and soft tissues expand, and swelling is more appreciated by sight than palpation. So the swelling is more visible than palpable. So it pushes the earlobe upward and outward. So, and one more thing is it subsides within 3 to 7 days, parotid gland swelling. The disease may be unilateral and it is tender and painful. So other things which can occur with mumps is like edema over the manubrium and upper chest wall may occur probably because of lymphatic obstruction. And submandibular glands, other salivary glands are also well infected. So swelling subsides more slowly than the parotids. Rarely sublingual glands are infected bilaterally. The swelling in the submental region and in the floor of the mouth. So actually this is not the mumps picture actually, but to show you that there is a swelling over the parotid region, I have kept this. Diagnosis. So how to diagnose the mumps? So basically it is a clinical diagnosis, mumps. So the clinical symptomatology and physical examination. So what are the laboratory features? So in the laboratory, mostly in the CBP, there will be leukopenia and relative lymphocytosis will be there. And because of the infection to the glands and other thing, parotid glands, mainly glandular tissue, there will be elevated serum amylase. So how we can diagnose serologically or by culture? So serology and culture always we will go for IgM and IgG testing, and virus culture from saliva, CSF, blood, urine, and brain. So what are the differential diagnosis? So all parotid gland infection is nothing but mumps. It doesn't mean like that. So there are other causes which causes similar parotid enlargement. So parotitis due to it may be because of virus or bacteria. So HIV infection can cause. So it is one of the WHO defining definitions in AIDS, parotid gland enlargement. And influenza can cause parainfluenza virus 1 and 3, cytomegalovirus, and Coxsackie virus. And it can be because of bacteria is like acute suppurative parotitis because of bacterial infection because of Staphylococcus aureus. And if there is any obstruction like salivary calculus can also cause parotid gland enlargement. And preauricular and or anterior cervical lymphadenitis may look like the parotid gland enlargement. And because of the complications of mumps, orchitis may also caused by Coxsackie virus. So these are the differential diagnoses you should remember and you should think of. So what is the treatment? So basically it's a supportive treatment. There is no antiviral therapy for the mumps. If the child has fever, we have to use antipyretics like acetaminophen or ibuprofen, and bed rest does not prevent the complications and should concentrate on the diet if ability to chew. If at all not able to chew, you should give lozenges or some other things so that it will improve. And orchitis treated with local support and bed rest. So mumps arthritis may respond to a 2-week course of NSAIDs or corticosteroids. And remember that aspirin is not effective. Okay. So complications with the mumps. So mumps it has predilection for salivary gland tissues and even for nervous tissue. So complications we have to remember is meningoencephalomyelitis. So basically aseptic meningitis, it can cause aseptic meningitis and even meningoencephalomyelitis. Even the brain tissue is involved. And orchitis, epididymitis, euphoritis, pancreatitis, thyroiditis, myocarditis, deafness, mm, and ocular dacroadenitis, optic neuritis, and arthritis. Okay, so prevention. So vaccine, the strain is Geril Lindstein. So before that, I have to say like Gerilyn. Who is Gerilyn? Gerilyn. Maurice Hillman developed this vaccine in 1967, and Gerilyn is none other than his own daughter, 5 years kid who developed mumps. So he isolated the virus from his daughter's saliva, and with that strain, he developed the vaccine, and which was used at present also. And uh, and Morris Hillman is the person who combined the vaccine, mumps vaccine with the to make it measles, mumps, and rubella. And later it was modified and it was accepted by US FDA. So Gerilyn is nothing but a kit. So So, so the ones if you get the infection, it is a lifelong immunity basically, ma'am. So it induces antibodies in 96% of the seronegative recipients. So if somebody has mumps, there is no point of giving mumps vaccine to that person. There is no use because it's a lifelong immunity. Once he gets the disease, he gets the immunity for the lifelong. So MMR vaccine is recommended at the age of 12 to 15 months of age. A second immunization also as MMR is recommended routinely at 4 to 6 years of age. So and the parotitis and low grade fever can develop 10 to 14 days after vaccination. So maternal antibodies is protective in the infant in the first 6 months of the life. So what are the contraindications to give the vaccine? So the MMR vaccine, MUMPS vaccine, all these vaccines, there is a little bit contradiction is there. Is going on since past actually. During 1955, at the time of the vaccine was developed, the MUMPS vaccine, there is a paper like MUMPS vaccine is the cause of Crohn's disease. And in 1988, and because there is a paper which shows that mumps vaccine or MMR vaccine is associated with autism and inflammatory bowel disease. Because of these papers and these things, there is a decline in the vaccination, and sometimes because of shortage of vaccine also, and sometimes because of those children who had not been vaccinated at that time. uh, and in the US, adolescent people got the mumps. So maybe those kids which have not been given vaccine at that time developed during the college days. Basically, it is, but it is a childhood disease. So 96% of the cases were below 15 years. So for whom we have to not give the mumps vaccine? Because allergy to neomycin, because neomycin is added in the MMR and mumps vaccine as stabilizer. So in moderate to severe acute illness with or without fever, and in case of immunodeficiency, primary immunodeficiency, cancer and cancer therapy, long-term high-dose corticosteroids, severely immunocompromised, including those with HIV infection. So mumps is nothing but the live vaccine. So live vaccines are contraindicated in immunocompromised and immunodeficient people. So, and in recent immunoglobulin administration, because the recent immunoglobulin administered child neutralizing effects over the vaccine. So MMR vaccine, this is measles, mumps, and rubella Tresivac. So it has to be diluted before giving it, and recently there is a new pre-filled syringe vaccines are available in MMR vaccines, and before the new pre-filled vaccines we have to dilute it and give with the distilled water. Diphtheria. So diphtheria is a Greek term actually, which means the leather. And before going to diphtheria, there is a big history for the diphtheria, because if you learn why this is important, still it is important even in India, and even the well developed countries also it is important, because diphtheria is cause of so many deaths in children actually. uh, because of the vaccine, it has been the disease, because of the immunization, the incidence of the disease has come down, but still there are the cases of diphtheria, and still there are the outbreaks which are going in some parts of the world. So actually in 1613, uh, the disease first occurred in the Spain, and it caused a lot of deaths in children actually. Ram Gopal. Ram Gopal. Yes. Sorry for the distance. Uh, so in the Spain, it has caused the death, so many deaths because of the diphtheria, and it was the first disease, the new disease. No one knows what's going on, what's there, and what is this. So similar to COVID, now we have the advances in medical and everything, so that we can diagnose it as early as possible. But at that time in 1613 there were no mm, good scientific things to know what is that. Sorry. So at that time the it was labeled as the year of strangulation. So you think of it. So because of diphtheria, most of the child died because of membrane formation in the larynx and pharynx, and unable to breathe. So they died. So it was labeled as a year of strangulation. And later on it spread from the France to the England. In 1826 it was called with different names, Bourguignon sore throat, because it spread from the France. And later on Perry Bretman, he named as diphtheria. So in 1821 Perry Bretman labeled this as diphtheria because of leather-like pseudomembrane formation. In 1883 and 1884, Klebs and Loeffler first identified this bacterium, and Loeffler cultured it. And you can go with the history, all other things, because it has created so many epidemics and endemics. In 1883, Edwin Klebs and Loeffler. And what you have to know is Emily Rocks uh, showed that because of some substances the disease is caused, that is nothing but the toxin. And later 1890 Emil von Behring, he introduced the toxin. He isolated the toxin and introduced the toxin in guinea pigs and the horses, and he developed the antitoxin, that is nothing but serum, anti-serum to the diphtheria toxin. And he literally saved because of developing antitoxin, which has become the treatment, standard treatment for diphtheria at that time. So, and he was given the Nobel Prize in 1919, and he was famously known at that time as the savior of the children. So you can think of it, how many children has been died because of the diphtheria. So it is still endemic in India and many parts of the country, and because of poor vaccination in some states in India. So this is the importance of the diphtheria, because knowing diphtheria is not the thing, but uh, we should improve the immunization mostly, so that we can prevent the disease. So the causative agent is Corynebacterium diphtheriae. The slender, irregular staining and non-motile and non-sporulating gram-positive rounds. So it produces exotoxin production A and B. A is the active and B is the binding site. Uh, B for binding. And humans are the only reservoirs. How you identify it? The colonies on tellurate agar, you label it as mites or intermediate or gravis, which have been learned in the microbiology. So KLEBS-LOEFFLER bacillus, the Chinese letter pattern. I think you already know it. The pathology is because of the Corynebacterium diphtheria, which forms a membrane. That membrane is adherent to the mucosa and bleeds on attempt to separate because of the production of the toxin. So the toxin is disseminated via blood to various organs, heart, nervous system, and the kidneys. And later on, the toxin binds to the tissues and cause necrosis, leading to the complications. So remember, because of the toxin, the major three organs are affected: heart, nervous system, and the kidneys. What are the clinical manifestations? So, clinical manifestation depend on which anatomical site is involved. So, anatomical site of membrane, the immunization status, and dissemination of the toxin, and time of presentation from onset. So, there are basically different types: nasal type, tonsillar, pharyngeal, laryngeal, cutaneous, oral, vulvovaginal, conjunctival, mixed varieties. Basically, you have to know these things. Tonsillar diphtheria, where the pseudomembrane formation is over the tonsil and in the pharynx, which can extend to the larynx also. Okay, and cutaneous diphtheria, this is a skin where necrosis has been formed because of the antitoxin. Hmm? So respiratory diphtheria, it involves tonsils, pharynx, and larynx as membrane form. So the underlying soft tissue edema and the enlarged lymph nodes cause the bull neck appearance. So infection of the anterior nares is common in infants and causes serosanguinous discharge. Patients with laryngeal diphtheria are prone for respiratory obstruction. Okay, so if it involves tonsils and pharynx, and later on it can involve the larynx. Sometimes it can involve the larynx directly, and because of the involvement of tonsils, pharynx, and the larynx, there is soft tissue edema, and the lymph nodes are being enlarged, valvular string. So it appears a bull neck appearance. Cutaneous diphtheria, more common in tropical countries. It presents as superficial, ecthymic, non-healing ulcer with gray membrane. So infection at other sites occasionally causes otitis externa, purulent and ulcerative conjunctivitis, purulent and ulcerative vulvovaginitis. Okay. So what are the complications? See, I have said because of the toxin, the three major organs are affected: heart, nervous system, and renal. So myocarditis. Myocarditis is a subclinical in 68% and clinical in 10 to 15%. It mostly occurs in the second to sixth week of illness, and myocarditis can develop during the diphtheric phase, like because of the toxin production, and because of the toxin there can be conduction defects, myocardial damage, and heart failure. And neurological usually resolves completely, but variable cases latent period they can have uh, post diphtheritic complications like palsies and other things. Basically, neurological features have a latent period, but myocarditis it can have a latent period or cannot have a latent period. So during the disease time only the child can present with myocarditis, or after the clinical disease also, after in second to sixth week of illness the child can present with cardiomyopathy features. Diagnosis. So it is important to diagnose the diphtheria as early as possible because we have to prevent it from laryngeal spread and other things, and child may require intubation, and sometimes it's a difficult intubation. And so as the intubation has come, you have to know because of diphtheria where the first fell is has done the tracheostomy, and later Dwyer has developed the with the help of Fellis to Dwyer's tube, that is a metallic or rubber tube at that time for laryngeal intubation. So so that's why the intubation child may require intubation. So it should be quick and essentially clinical, and it is very important to administer the antitoxin early. So initial evaluation should be for the following: interval from the onset of symptoms, and the way the anatomical site is involved, and what is the degree of toxemia, and immense of mechanical obstruction to the airway, and what is the immunization status. So laboratory features basically complete picture shows neutrophilic leukocytosis and anemia. Blood urea nitrogen may be elevated because of involvement of the renal system, and CSF proteins can be raised, mild pleocytosis. ECG must be done regularly to see for ST and T wave changes and arrhythmias, because child can have uh, ha- arrhythmias, conduction defects, and myocardial enzymes are elevated because of myocarditis. And microbiological on blood agar it forms a white colonies, pearly white colonies, and tellurite black colonies. Okay, this is a picture on blood agar and on tellurite medium. So management: all patients should be isolated till three consecutive cultures are negative. Okay, so diphtheria antitoxin should be administered after test dose, keeping resuscitation ready. The dose depends on the site, degree of toxicity, delay from the onset, and not on age and weight. So the doses depend mostly on the site and degree of the toxicity. And It should be given as a single IV dose over a few hours, and serum sickness can occur in 10% of the people because of antitoxin horse serum is used. So there is a chance of serum sickness. Okay. So antibiotics. So penicillin, aqueous procaine penicillin, 3 lakh to 6 lakh international units IM daily for 14 days, or else in case of penicillin allergy, erythromycin 40 mg per kg per day in 4 divided doses for 14 days. So, and other antibiotics that can be used is amoxicillin and rifampicin and clindamycin. And for carrier, uh, procaine penicillin like 6 lakh for 4 days, and oral penicillin 2 lakh QID for 4 days, then erythromycin 40 mg per day for 1 week. Supportive treatment, bed rest at 2 to 3 weeks, hydration and high calorie liquid diet, and carnitine prophylaxis. This is nothing but to prevent the cardiomyopathy or cardio, to decrease the cardiac effects, because with the help of carnitine free fatty acids can be used by the muscle. Uh, so carnitine prophylaxis 100 mg per kg per day for 4 days to prevent myocarditis. Steroids are not to be given in case of this myocarditis. Okay. So what is the treatment of complications? If there is a laryngeal obstruction, intubation or tracheostomy may be needed for the child, and if in case of myocarditis, the bed rest should be given, and treatment for arrhythmias and anti-failure treatment like diuretics, ACE inhibitors, digoxin. So in case of neuritis, there is no specific treatment. Most of the times it is self-limiting, may require gavage feeding if there is a palatal palsy or some other thing. So immunization after recovery is a must, because diphtheria. So see, mumps, one time infection, lifelong immunity. But in case of diphtheria, the immunity doesn't last long, and even if the infection has occurred to the child, it doesn't give full protection. So immunization after recovery is a must. So prevention among contacts. So how to prevent this isolation? So you all people know the isolation, and sample collection for culture, and in case uh, culture positive, chemoprophylaxis can be given benzathine penicillin single IM dose. Okay, 6 to 12 lakh units, and erythromycin 40 mg per kg or 1 gram per day for 7 to 10 days. And even immunization and antitoxin is not recommended in case of contacts, because these are not clinical people. There is only these contacts have this bacteria, but they doesn't have any symptoms. These are just contacts only. So coming to pertussis. So pertussis, whooping cough. So coming to the epidemiology, it is an acute respiratory infection caused by Bordetella pertussis and occasionally Bordetella parapertussis, characterized by intense cough or whooping cough. So it was like whooping cough. Previously, it was called like a cough fits, basically fitting cough or cough fits, like the fits seizures. So the cough is like that only. Continuously, the child used to cough like bouts of cough, 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 and d- uh, he takes a deep inspiration with a woof. So during the pre-vaccination era, pertussis was the leading cause of death due to communicable diseases. Though there has been dramatic decline in the incidence with the good coverage of pertussis vaccine in developed countries, in underdeveloped countries it is still endemic and sometimes epidemic due to low vaccine coverage. So India is also same. It is still you think endemic only. So the transmission is by aerosol droplets and highly contagious. Organism does not survive in the environment for prolonged periods. So no lifelong immunity with natural disease or vaccine. Even with full immunization schedule, the immunity wanes by 12 years. So this is also has uh, immunity wanes off by 12 years. So now the disease, so think that even if you are vaccinated, the disease can come during the adulthood or adolescent age. So there is an increase in instance in the adolescent and adult also, because of the waning immunity. So yeah, and it is not fully protective. Basically, the vaccine and everything, and even the infection is not fully protective because the immunity wanes by 12 years. So what is the pathogenesis? Like Bordetella pertussis is a tiny gram-negative bacilli, and it produces pertussis toxin and filamentous hemagglutinin, fin type 2 and type 3, and petactin, producing local epithelial damage in the respiratory system. Okay, so clinical features. So basically, pertussis has three stages: catarrhal stage, paroxysmal stage, and convalescent stage. So catarrhal stage, it's nothing but it's look like viral cold, congestion, rhinorrhea, conjunctival suffusion. It begins after an incubation period of 3 to 12 days. Paroxysmal stage, cough is initially a dry, intermittent, and irritative hack and evolves into paroxysms. So young infant. So in case of the child, it is like intense cough or dry cough, which have paroxysms, and in case of young infants, cough cannot be much symptom, but they can have apnea like features. So they can stop breathing. Young infants, the symptoms are very severe, even may choke and gasp. Move more often observed in toddlers. Okay, and at the peak of paroxysmal stage, episodes of cough are more. So cough increases during the paroxysmal stage. So this is a pic of a whooping cough where the child feel like he's like choking because of the cough, intense cough, and because of the cough there can be fractures of the rib, conjunctival hemorrhage. Okay, so that is you can think the intensity of the cough. So convalescent stage, intensity and paroxysms of the cough decrease gradually over 1 to 4 weeks. So even it starts, the intensity increases in the paroxysmal stage cough, and even it continues in the convalescent stage also. So basically in convalescent stage there is an increase in appetite, general condition and health improves, but cough doesn't subside that much easily. So because it can be there for 10 weeks to 12 weeks approximately. So it was considered like a 100 days cough by Chinese. So whooping cough or a 100 days cough. So this is a timeline of the disease progression. So 0 to 2 weeks there is a stage 1 catarrhal stage, may last from 1 to 2 weeks. So what are the symptoms of catarrhal stage? Like runny nose, low grade fever, mild occasional cough, highly contagious during this phase. Okay, and stage 2, the paroxysmal stage. So it lasts from 1 to 6 weeks and may extend to 10 weeks also sometimes. So from 2 to, remember, like 6 weeks, from 2 weeks to 8 weeks. Okay, what are the symptoms? Fits of numerous the fits of numerous rapid coughs followed by a woof sound. So post cough there can be vomiting and exhaustion after coughing fits. So paroxysms. So stage 3, convalescent stage. It lasts about 2 to 3 weeks, again from 8 weeks to 12. So susceptibility to other respiratory infections can occur, and recovery is gradual. Cough it decreases slowly. So the diagnosis. So most of the times the diagnosis is clinical. So suspected when intense cough without fever, malaise, myalgia, tachypnea, wheeze and raise. And in blood picture there is a leukocytosis like 15,000 to 1 lakh due to absolute lymphocytosis, and is characterized in initial stages. So X-ray chest mildly abnormal, and bacterial isolation from nasopharyngeal swabs or cough plate culture from BORDET-GENGOU medium. So this is the BORDET-GENGOU medium. So some fairly structures. Okay, and so what are the differential diagnosis? See, pertussis, it can have similar conditions like cough. We call it as pertussoid cough. So repeated bouts of coughing will be there. So other conditions which may mimic protracted cough include adenoviral or influenza, parainfluenza viral infections, mycoplasma, chlamydia, and endobronchial TB sometimes can present like this, and inhaled foreign body and reactive airway disease. So complications: infants less than 6 months of age, excessive mortality and morbidity. Okay. And respiratory complications like otitis media, pneumonia, uh, atelectasis, emphysema, bronchiectasis, pneumothorax, and pneumomediastin. And the neurological seizures and encephalopathy, bleeding, epistaxis or conjunctival hemorrhage. Because of the cough, there can be rectal prolapse also, and inguinal hernia, and malnutrition, flare up of tuberculosis and secondary bacterial pneumonias because of the decrease in the immunity. So the treatment, so adequate nutrition, hydration, and avoid aggravating factors for the cough. Okay, erythromycin 40 to 50 mg per kg in 3 divided doses for 14 days, and nebulization may be required sometimes with salbutamol. It may be helpful, but no cough suppressants and antihistaminic agents. So younger infants may require hospitalization. So for prevention, chemoprophylaxis with erythromycin for close family contacts, and immunization with the pertussis vaccine. So the pertussis, there is a two type of vaccine: whole cell vaccine and acellular pertussis vaccine. So basically, uh, diphtheria, tetanus, and pertussis. It's a trivalent vaccine, combined vaccine. Uh, it was given for 5 doses, like 3 doses in the first year, 6 weeks, 10 weeks, and 14 weeks, and the first booster dose at 16 to 18 months, and the second booster at 5 years. So basically, DTP wholesale is not recommended beyond 7 years, as adverse reactions are more with more doses. Okay, and it is contraindicated in progressive neurological disease or history of severe side effects with previous doses. So basically, after 7 years, we don't prescribe to give wholesale vaccine or some wholesale pertussis vaccine, and there is a decrease in the dose of diphtheria. So DTaP can be given after 7 years. So you have to know about the vaccines. So all the vaccines, MMR vaccine, and you should learn about the MR campaign also, measles and rubella campaign, and DTP vaccine. It is a trivalent vaccine, but now it has combined with hepatitis B, uh, Haemophilus influenza. It is called pentavalent vaccine now. So you have to know about the pentavalent vaccine. The trivalent vaccine is DTP, and pentavalent is more two things are added, like hepatitis B and HIP. And there is a hexavalent vaccine is also there. So it contains IPV. Okay, so you have to know all these things. You have to go through the vaccines. You read once. So this was given by CDC poster actually. So people of all ages need diphtheria vaccines. So even diphtheria and pertussis, because the pertussis vaccine also immunity also wanes off. So in case of children, young children, the acellular pertussis, or it can be wholesale pertussis. Because of the wholesale pertussis, there is a little bit of complications like neurological complications, some other thing. Some people avoid wholesale pertussis, but both have equal efficacy only. But as per national immunization schedule of the India, wholesale pertussis is preferred. So TDAP for preteens 11 through 12 years, and TD or TDAP for adults, single dose of TDAP in adults, and booster doses with TT every 10 years. So thank you. And I think tetanus has not been covered. You go through the tetanus by yourself, and the important of the tetanus, you have to know why tetanus in children is important, and why it is given in TT doses were given in the pregnancy. Because neonatal tetanus is a cause of death in neonates previously. So that's why you have to know about the tetanus. Tetanus can occur in adults also and children also, and even in the neonates. So you go through the tetanus and TTP vaccine, tetanus vaccination, and take home message is nothing but these are the all these diseases can be preventable, prevent because vaccines are there. So vaccine preventable diseases, and the important thing is, and every child should get vaccinated basically, and 100% coverage should be there. And the basic role of every doctor is to encourage for the vaccinations. So some people may have the idea that because of vaccinations there can be autism, because some papers were there. Even most of the people are googling everything, so they get the nonsense stuff into their head, and they think vaccination is detrimental and everything. But you should outweigh the risks benefits. So vaccination and immunization has a good benefit than the risk. So you should encourage everyone to take vaccines. So good vaccine coverage will prevent the diseases. So this is the take home message basically. And most of the things in the mumps and diphtheria, pertussis, most of the times you have learned from the second year, you know most of the things. uh, the thing why I said the history is you should know the importance, because the disease is deadly. Diphtheria was once considered as a deadly disease in children. So similar to the COVID, you think. So it is considered as a deadly disease. So that's the thing you have to know, because if you know the importance, you know the why the disease is important. And you think intubations were done in 1813 somewhere around at that time in children, which was very difficult with diphtheria. So, and there is so many things has been diphtheria showed, but vaccination is the important thing. So you should encourage everyone to take vaccines mainly. So these are the vaccine preventable diseases basically. Thank you.